Hello, everyone. Can you see me now? Okay. Okay, let's begin. Hello, everyone. So good morning. So today I will introduce a very important capture of the infectious disease. Is the capital names is typhoid fever and paratyphoid fever. And my name is Xiaoyong Zhang. I'm from Hepatology Unit and Department of Infectious Disease, Nanfang Hospital, Southern Medical University. So nice to meet you all of you. So what is typhoid fever? Here is the definition. Typhoid fever is a bacterial disease. The bacterial's name is Salmonella typhi. So we should know the pathogen of this disease. Secondly, it is characterized by prolonged fever, abdominal pain, diarrhea, delirium, rose spots, and splenomegaly, and complicated sometimes by intestinal bleeding and perforation. So here is the symptoms and also some signs of this disease. So this also is very important for the diagnosis of this disease. The second, enteric fever, is synonymous with typhoid fever. Actually, enteric fever is another name of the typhoid fever, so it's the same disease. Today, I will introduce this disease history, etiology, and as well as the complications, diagnosis, and the prognosis treatment. So we have three classes today. Firstly, let's look back to the history of this disease. The left picture shows a physician. His name is Thomas Williams. Actually, he is credited with the first description of typhoid fever in 1659. So it's about 500 years ago. This physician from Britain first described the disease with persistent fever, relatively slow pulse, neurotoxic symptoms, splenomegaly, rose rash, and a few cases with intestinal bleeding and intestinal perforation. So then he gave a name for this disease. It's called typhoid fever, and describe it as a different disease with typhus. So after the description of typhoid fever, another physician, William Wood Gerhardt, he was the first to differentiate clearly between the typhus fever, which caused by the rickshell, and the typhoid fever in 1837. So describe these two diseases are caused by different pathogens. Although they have very similar symptoms, but it's a different disease. And then in 18, he discovered called the typhoid bacillus. Carl Joshua Ebers, he discovered the pathogen, the bacterial called the typhoid bacillus. He isolated a shorted, flagellated, viable bacterium from the fecals of the typhoid patients, and then fed confirming the pathogenic bacteria of the typhoid fever. So this is very important for the identification of this infectious disease. Last, a very important person called Georges Vidal. He described the Vidal aggregation reaction of the blood in 1896. He developed a method for the detection of the typhoid fever in the lab called the Vidal aggregation reaction. We collect this method is used to collect the serum from the patients and then assess the different levels of the antibodies in the patients in the typhoid fever. So this is an antibody antigen response. So it's very important in the diagnosis of the typhoid fever, which especially in the last century. Now we come to the etiology. Etiology, as I described before, that is caused by typhoid bacillus. The exact name of this bacteria is Salmonella typhimurium. This bacteria belongs to the group D of the Salmonella, and the Salmonella belongs to the family of Enterobacteriaceae. It is a very large group of gram-negative bacilli, and that are parasites in the gut of humans and animals, and with similar biochemical reactions and antigenic structures. So it's from this bacteria from a very large, very big family. And the other smaller serotypes, particularly as enterocase serotypes, we call it the paratyphoid. A, B, C. They can also cause a very similar syndrome. So they could cause a similar disease, but from a different pathogen. And this different pathogen, they are from the same bacterial family. But generally, paratyphoid fever is milder than typhoid fever. So maybe the symptoms and the progress is better than the typhoid fever. So this is the pathogen of this disease. And then we go to the detail of this pathogen. Firstly, the morphogenic characteristics. So from the staining, it's gram negative bacillus. So its color is red, not blue. And it's about 0.6 to 1 micromolar wide and 2 to 3 micrometer in length. So it's not very small, but it's very easy to be found in the microscope. And the structure of this bacteria, they have low capsule, no spore, but with flagella, and it can release endotoxin. And they in the bio-containing culture medium, it grows better. So generally, in the chronic care of typhoid fever, it's very easy to find this bacteria in the blood. Here shows this picture shows the antigen of the bacteria. They are located in the cell capsule. It has 3 antigens. H antigen is an antigen of the flagellum. So we call it the H. And the O antigen is a somatic antigen. It's a cell wall antigen. And we have it have another antigen called the VI antigen. Actually, it's a polysaccharide. They can protect from the antibody for the neutralizing of the O antigen. So it's a virulence of the bacteria. So the viability, generally the Salmonella typhimurium is highly resistant in the nature. Resistant to low temperature, can survive for 2 to 3 weeks in the water, and can survive for 1 to 2 months in the feces. And can survive for several months in the milk, meat, and eggs. So it's in the food. It can survive for a very long time, and they can cause the transmission of this disease. But for the inactivation, heat, dry, and acid, they both can destroy the bacteria. So it's very sensitive. And they can die in the direct sunshine for several hours, and 60-degree or boiled water can sterilize. 60 for 10 minutes or boiled water can sterilize this bacteria. Now, next we come to talk about the epidemiology of this disease. So, typhoid fever continues to be a global health problem. It can be found in the areas with a high incidence, including the Asia, especially Southeast Asia, Africa, and Latin America. and it affects about 6 million people with more than 600,000 deaths a year, 80% in the Asia. So in the Asia, this disease is really a great public health problem. The sporadic occur usually, but sometimes have epidemic outbreaks, especially some disaster that comes, like the earthquake and so on. And last, very important, the humans are the only host of these pathogens. So this typhoid fever can only infect the human patients. Now let's identify the source of the infection. And this is very important for the characteristic of the infectious disease. The source of infection of typhoid fever is cases and chronic carols. The cases can discharge from incubation more in 2 to 4 weeks after the onset. A few, about 2 to 5%, can last longer than 3 months. So we need to isolate the patients. And the chronic carol, they can discharge the bacterial constantly, even from days to years. A very famous person which have a chronic carol is Typhoid Mary. Who is Typhoid Mary? Actually, typhoid fever was a cook in the Oyster Bay, Luke, in 1906. She is known to have infected 53 people, 5 of whom died. And later, she changed his name, but detained and quarantined after a large typhoid outbreak. So she caused 2 times of typhoid fever outbreak. At last, she died of pneumonia after 26 years in quarantine. Otherwise, because the doctors have no effective antibiotics to treat the typhoid Mary, so they cannot cure. It's a fecal, the transmission of take some contaminated water and food. Last is the flies and the cockroaches. They can also cause the transmission of this disease. The last is the susceptible population for this disease is children and the young adults. Individuals who have not had typhoid fever and have not been vaccinated against typhoid vaccine. All of these patients are susceptible to the typhoid fever infection. The long-lasting immunity is obtained after the disease, and 2% of patients can get sick again. So this is sometimes like a virus infection. So the protective immunity and the post-infection immunity can exist for a relatively long time than other bacteria. Now, next we come to the pathogenesis. How does smaller typhoid cause the disease? This bacteria can be ingested orally, and then through the stomach barrel. But in the stomach, some of the bacteria can be eliminated. But actually, some bacteria can enter into the small intestine, and then penetrate the mucosa layer, and then enter into the molecular phagocytes of the ileal patches and mesenterical lymph nodes. So it can enter into the Paya patches and mesenterical lymph nodes, and then proliferation in the molecular phagocytes and spread to blood and cause the first bacterial meal, or called the initial bacterial meal. So it's an incubation period generally lasted for 5 to 21 days. So when it's amplified in the blood and the other organs, they can enter into, through the blood, they can enter into the spleen, liver, and the bone marrow. It's generally all of these can be called the reticular endothelial system, and then they further proliferate. They can further proliferation occurs, and then a lot of bacteria can enter into the blood again. We call it the second bacterial meal. And last, and then through after this time, and the host immune system will try to kill this virus. Sometimes some patients can be recovered from this infection, and during the second bacterium, we generally have some symptoms like fever, nausea, abdominal pain, diarrhea, and so on. So this is the pathogenesis of the typhoid fever. And then we talk about the pathology. The pathology feature of the typhoid fever is the proliferative response of the mononuclear phagocyte system throughout the body. So the lesions of the collective lymph nodes and the solitary lymph follicles in the lower ileum are the most characteristic. So let's see some pictures. This is typhoid noodles. We can see these red arrows. We can see some necrosis of the cells, epithelial cells, and also the proliferation of the lymphocytes. So it's a very specific change in the lymphoid tissues and the mesenterical lymph nodes. And the second is the ulceration of the mucosa. And we can say that the ulceration of the mucosa is in the regions of the past batch of the small intestine. We can see here like this, and this is the inside, and this is the outside. Now, next we come to the clinical manifestations. The clinical manifestation for typhoid we were divided into different periods, as I described in the pathogenesis. Firstly is the incubation period. Generally, this period is about 1 or 2 weeks, but sometimes it takes from 3 to 60 days. The incubation period, for the early stage, is initial period in the first week, and the insidious onset. The fever can up to 39 to 40 centigrade in the 5 to 6 days. The patient will have chills, ailment, tight, some throat, cough, abdominal discomfort, and constipation, and so on. So they have some unspecific symptoms in the initial period, generally less than 1 week. And then it enters into the fast growth stage. From the name, we know that it's like it have typical symptom and signs. The fast growth stage is usually after onset. Is usually second and in second. Sustained high fever and partly remittent fever or irregular fever, but it lasts 10 to 40 days, but mostly sustained high fever. And the patients have a gastrointestinal symptom. Diarrhea or constipation. In some very ill patients, they might have neuropsychiatric manifestations like confusion, blunt response, even delirium and coma or manism. So this is the first growth state. And in addition to the gastrointestinal symptoms and the neuropsychological manifestations, they have some like circulation system, like a relatively bradycardia. We also call it slow passing, and the splenomegaly and the hepatomegaly. Some patients will have toxic hepatitis. And lastly is the rosella. So we can show the red spots in the skin. It's occurred in the 30% of patients. It's a maculopapular rash. And the faint pale color, slightly to then 10 it disappears. Figure shows the picture of the rosella. We can show the red spots in the chest, in the skin of the chest. After the fastigial serum stage, then it can enter into the defervescence stage. And in the defervescence stage, fever and most symptoms resolve by the 4th week of the infection. And the fever comes down and gradually improvement in all symptoms and signs. But this time it's still danger. Last is the convalescence stage. Is in the 5th week, and the disappearance of all symptoms. Sometimes it can relapse. So this is the picture. I think it shows the dynamic of the body temperature of typhoid fever patients. We can say after the onset of the infection, we can see the increase of the body temperature is generally is the here is we can be classified into the incubation period, and then it go to the fastidial period. And last is the quiescence period. The below of the temperature is the pulse. We can see some patients, the pulse is under the normal condition. Let's talk about the two definitions about recrudescence and relapse. Recrudescence is some patients with typhoid fever begin to decline after 2 to 3 weeks of illness, but have not returned to the normal. This we talk about the body temperature. The body temperature can rise again and last for 5 to 7 days before returning to normal. We call it the recrudescence. So, in addition to recrudescence, there is another definition we call the relapse. Is that a small number of the typhoid patients can reappear after 1 to 3 weeks of fever, and then the blood culture was very positive again. So generally, we usually use body temperature to identify whether there is a recrudescence or relapse. So in the recrudescence, the body temperature are not returned to the normal, but it increases again. So it's a recrudescence. And the relapse is the body temperature can return, have been returned to the normal level, and then if the bacterial proliferation again, and the body temperature will increase. So it's a relapse. It's a little bit different. Okay, let's go to the laboratory findings. This is very important for the diagnosis of the infectious disease. First, some routine examinations. We need to detect the examination the blood. Generally, we can say the white blood cell count is normal or decreased. So there is a low, not like other bacterial disease, the white blood cell can increase, but then this count is normal decreased. We can observe the leukocyte panel, especially endophilic or the leukocyte panel, reduction of the leukocytes count. And if the white blood cell count can recover, they are returned to normal, it generally reflects the recovery or the improvement of the disease. And so if the patient have a relapse, and this WBC count can decrease again. So this is a routine examination, the blood examination. And secondly, very important, the pathogen examination, also called the bacteriological examination. The first choice is the blood culture. It's the most common use, and 80 to 90% positive during the first 2 weeks of the year. So we can see the positive rate is relatively high. So it's a gold standard for the diagnosis. It decreased like 50% in the third week and not easy in the fourth week. So because in the later phase, it's very hard to detect the bacteria in the blood. So it's very easy to detect it during the proliferation of the bacteria in the blood. So the blood culture can be very positive when relapse and recrudescence. So if the bacterial culture is negative, we need to pay attention to the use of antibiotics, because it sometimes can cause the cause the 这个negative results. So in addition to the blood culture, the second choice is the bone marrow culture. Bone marrow culture is the most sensitive test. So it's more sensitive than the blood culture, and so it generally is used especially in the patients pre-treated with antibiotics, because after the use of antibiotics, it's not very easy to detect the have positive culture results. So we also can use urine and stone cultures. They will be helpful to increase the diagnostic yield, and but generally they are positive. They are less frequently, and perhaps maybe in the 3 to 4 weeks, the stool culture will be better. Must the dual strain test to the culture by acid is useful for the diagnosis of the cultures. So, but it's not very useful to do this for the diagnosis. And lastly, the rose spots is not used routinely. So it's just symptoms, but cannot be used only for the diagnosis. Beside the blood or bone marrow culture, another very important method is the serological testing, which I mentioned before as the VIDA test. This test detected the O or somatic antigen, the H or flagell antigen, and the VI or virulence antigen. We call it the VIDA test. The diagnostic titles are 1 per 80 for O antibody, 1 per 160 for H antibody. And the titles of post samples is at least 2 double of the former, then we can make a diagnosis of this typhoid fever. And the detection of VI antibody is not used very frequently, but it's if it's more than 1 per 40 can be used in diagnosis of chronic carols. And the O antigen aggregation becomes positive at any stage and decrease soon. So H antibody may be positive after 7 to 10 days of the ERDs. We can see that the detection window of these two antigens, they are not very long. So we can use this test for in some developing regions. So if they have low bacterial culture systems, they can use this test. Now, next we talk about the complications of the typhoid fever. They have two very important and frequently, not frequently, it's just 2 to 5% incidence: intestinal hemorrhage or intestinal perforation. So firstly, the intestinal hemorrhage, this complication, they commonly appear during the second to third week of the ERDs. They have difference between the mild and great bleeding, often caused by unsuitable food, diarrhea, and so on. And the serious bleeding in about 2 to 8%. We can So in these patients, they will have a sudden drop in temperature, rest in the pulse, and signs of shock, followed by dark or fresh blood in the stool. So actually, it's relatively easy to detect the intestinal hemorrhage because we can use like the gastrointestinal microscopy now, so it's very easy to identify it. And the secondly is the intestinal perforation. This is a very serious communication, and the incidence is 1 to 5%, 1 to 4%. They commonly appear during 2 to 3 weeks, so it's similar as the intestinal hemorrhage. They can take place at the lower end of ileum. And before perforation, the patient will have abdominal pain or diarrhea or intestinal bleeding. So when the perforation occurs, the patient will have abdominal pain, sweating, drop in body temperature, and increase in pulse rate, and then rebound tenderness when pressed the abdomen. And the temperature can raise, and we can find the peritonitis. The last is the celiac free L and the X-ray. You can find these signs. We also have some other complications like toxic hepatitis. It's common. It's very common into 1 to 3 weeks, and if you do the body examination, you will find the hepatomegaly and the ALT elevation by blood test, and it will get better with improvement of disease in 2 to 3 weeks, and also some other toxic on the other organs like the toxic myocarditis or the bronchitis or the bronchopneumonia. So, but these complications are not happen very often. So let's have a 5 minutes break. Hello, let's continue to talk about the typhoid fever. Now let's talk about the diagnosis of typhoid fever. So from diagnosis of the infectious disease, we need to know 3 points of the science. Firstly is the epidemiology finding. So if they have taken some contaminated food or contacted with some infectious patients and so on. And the next, we need to do the clinical examination to find some typical signs or symptoms. Ask the patients, like the road spots or have some gastrointestinal uncomfortable, and so on. And the last but very important is the laboratory investigation, the low blood cell count and positive of radar reaction or blood and bone marrow culture. This is a gold standard for the diagnosis. Otherwise, we can also perform the stool and the urine culture. Here, this picture shows the diagnosis of the enteric fever by comparing with different methods. We can see after the onset of the infection, the weather test, the positive weather test can be lasted from first week to fifth or more than fifth week. And the bone, the blood culture comes to 80 to 90% from 1 to 4th week. And the bone marrow culture is generally positive 90% from 2 to 4 weeks, 4th week. And the urine culture is less positive. It's after the 4 weeks of onset is only about 25% to 10%. But the fecal culture is the positive rate is 80% from 1 to 2 week, second week. And then it goes down from 2 to 5th week, it goes down to 15%. And after this, it continues to decreasing positively. So from this picture, we know that when and how to choose the examination for the diagnosis of the typhoid fever. Next, some differentiation diagnosis. I think it's sometimes by the pathogen identification, it's very easy to differentiate this infectious disease with other infectious disease. Like the lower levels, they usually cause some symptoms in the patients. Upper respiratory tract infections, and the symptoms can abrupt onset and so and the course of illness is generally no more than 2 weeks. And the differential diagnosis depending on the typical manifestation and the blood culture is very important. And therefore, paroxysms often periodic of sequential chill, high fever, and sweating. And the patient will have a headache, anorexia, splenomegaly, anemia, and leukopenia. And the characteristic parasites in the aerosol site. So we can examination, and they're very easy to differentiate malarial to the typhoid fever. So then we talk about the treatment, and this is a bacterial disease. So generally we need the antibiotic treatment, but firstly we also need some general treatment to contact the symptoms and signs. So firstly, the general treatment is the isolation and rest, because it can discharge the bacterial and may be cause the epidemic of this disease. So we need to isolate the patients. And secondly, the good nursing care and supportive treatment, like close observation on the temperature pulse, respiratory rate, blood pressure, abdominal condition, and stool. And we can give patients with suitable diet, includes very easy digested food or half liquid food, and drink more water. And we also can intravenous injection to maintain water and acid base and electrolyte to make the electrolyte balance. So it's a general treatment. For the second is the symptomatical treatment. So for high fever, we need to do the physical measures firstly, and we can give patients with antipyretic drugs such as aspirin. But when we give the aspirin, we should pay attention to what it can cause the stomach hemorrhage, because this anti-inflammation drug usually have this side effect. And for the delirium, coma, or shock, we can give 2 to 4 microgram dexamethasone in addition to the antibiotics. It can reduce the mortality. The third is the etiological and special treatment, where actually is the antibiotic treatment. The first choice by antibiotics is the quinolones. So it is have highly effect against the salmonella typhoid. The mechanism for this antibiotic is penetrate cell wall into the macrophages and achieve high concentration in the bowel and the bile loops. Then it interrupts the proliferation of the bacteria. So generally, this class of antibiotics have 3 drugs. First, like norfloxacin, we can give 0.1 to 0.2 TID or QID for 2 weeks. Or we can give ofloxacin, 0.2 gram TID for 10 to 14 days. Or we can give ciprofloxacin, 0.25 gram TID. We should make a caution that these antibiotics should not be used in the children and in the pregnant patients. The second antibiotics is the cephalosporins. From the cephalosporins, only the 3rd generation cephalosporin are effective, because it have anti-gram-negative bacterial effects. We have generally use 2 drugs, the cefoperazone or the ceftazidime. We can give 2 to 4 grams per day for 10 to 14 days. The 4th treatment is the to contact the complication. Firstly, the intestinal bleeding. We should ask the patient have a bed rest, stop diet, close observation of the temperature, body temperature, pulse, respiratory rate, blood pressure, and we can give intravenous saline and blood transfusion and attention to the acid-base balance. And sometimes we need some operation to we down the stomach pressure and the intravenous injection to maintain electrolyte and acid-based balance. And we need the use of antibiotics, and sometimes we need an operation to revise the intestine. For the toxic myocarditis, we also need a bed rest, cardiac muscle protection drugs. The best choice is the dexamethasone or digoxin. The fifth part for the treatment is for the chronic carrier. This is very important for treatment of chronic carrier because it can be the source of the infection of typhoid fever. So we have many choices, like we can give the drug aflatoxin 2.2 BID or ciprofloxacin 0.5 BID for 4 to 6 weeks. So we need to treat for a relatively longer time, about a 1 month treatment period. And we also can give an ampicillin 3 to 6 gram day TID plus P probenecid 1 to 1.5 gram per day, also 4 to 6 weeks. And also we can give TMP with SMJ, these two biotics BID for 1 to 3 months. So if the patient have a cholecystitis, so we require the cholecystectomy. So we need the operation. For the prognosis, generally the case fatality of this disease is 0.5 to 1%. So it's not very high in the developed countries, actually, but relatively high in the older ages, infant and serious complications. So that's the reason why you should pay attention to this disease. And from after infection, about 3% of patients become the fecal carriers, also the chronic carriers. So it's very important to identify these patients and give them a relatively longer treatment to reduce the transmission rate. At last, we talk about the prevention, because for the infectious disease, it's very important to prevent the occurrence of the infectious disease. The treatment is the second choice. For prevention of this disease, it's similar as other disease. We need to do 3 things. Firstly, is the management of the source of infection. We need the treatment of suspected carrier, and the patients must have a stool examination when finish isolation. And then second is cut off the root. So we need to pay attention to the personal hygiene, and public hygiene and insecticide or do the disinfection. And lastly is the and then second is cut off the root. So we need to pay attention to the personal hygiene and the public hygiene and the insecticide or do the disinfection. And lastly is the protect the susceptible population. We need to do the active immunization. Now we have the vaccines. So if we go to some region with a high incidence of typhoid fever, we can do the vaccination first. So it is also very effective to protect the infection. Lastly, I want to talk a little about the paratyphoid fever. Paratyphoid fever including 3 subtypes, A, B, C, respectively. So it's epidemiology, pathogenesis, pathogenic anatomy, clinical manifestations, diagnosis, treatment, and prevention. So it's generally very difficult to distinguish clinically, and it is necessary to perform wide reaction and bacterial culture for the diagnosis. But in clinical, we generally use blood culture for the differentiation diagnosis. So to make a typhoid fever and paratyphoid fever, they are active digestive tract infections caused by the pathogenic Salmonella bacillus. So it's a bacterial disease and causes the digestive tract infections. Secondly, chronic carrier are the main source of infection for the spread and the prevalence of this disease. So we need to identify the chronic carrier and treat them for about 4 to 6 weeks. And the third point, the 6 clinical splenomegaly, leukopenia, and major complications including the intestinal bleeding or intestinal perforation. The fourth point is the laboratory characteristics. We should perform the blood examination to examine the peripheral blood WBC, white blood cells. We can say the decrease of the WBC, the decrease of the eosinophils or disappeared. And we can use the gold standard method is the bacterial culture or redox reaction. The fifth point is the main differential diagnosis of disease is the persistent fever or peripheral white blood cells decline, which is sometimes caused by the viral infection or malaria. The sixth point is the antibiotic treatment is very effective. We can use the quinolones or the cephalosporins, third generation. So the last point is the cut off the root of the transmission is the mainstream to prevent and control typhoid fever because the vaccination is very popular. We just give the just give some patients with a high incidence region. So that's all the content we talk about today. At last I want to thank all of you for your attention. So if you have any question, you can send an email to me or send some message in the app. I will be very happy to answer all of you. Thank you. Bye bye.